Hello, I'm Franklin from Hamsa Rehab Medicines, and today's topic is going to be stroke critical appraisal. And I welcome you one and all, behalf of Hamsa. And this is going to be an enlightening topic and different kinds of approaches, which we have been already following it. And it will be going to be a critical appraisal. What type of approach will be good and which will be appropriate for handling stroke patient. I am hereby welcoming Dr. Arunachalam Ramachandran. He is a PhD in physiotherapy and he has done his MPT in neurology, and he is working as a principal in Madhav University in Gujarat, Rajasthan. Sorry, and once again, thanks a lot for joining us. If you have any questions, there is a Q&A where you can type your questions, and in between you'll be getting polls also. You can even answer it, and the question and answers will be done in last 10 or 15 minutes. Okay. Hereby I'm going to present Mr. Dr. Arunachalam Ramachandran. Sir, please take it, sir.
Thank you, Franklin, and thank you to the Hamsa team for putting up such a show, that too during this crisis period. This crisis period is maybe a godsend gift for a professional like us, I guess, because we are staying connected now. We are learning a lot. Maybe we don't have much of field work as of now. So I guess this is a good time to discuss all these theories. We have to make ourselves fit to go back into the community and serve better. So I think I can share my screen now. I need a host permission for that. Can I screen? Yeah, I can share now. Am I visible?
Yes, of course, sir.
Okay. So this is the topic we are going to see. It is a critical appraisal of approaches in stroke rehabilitation. I'm going to give a critical analysis from my point of view. It is not an evidence-based approach or something like that. Of course, my opinion will also echo the evidences, but I'm not going to quote any researchers as such here. It's going to be a casual discussion about all the approaches what we have seen and we have come across in our rehabilitation of stroke patients. Fine. So what we are going to see today, three very important things. First is the functional approach. What is functional approach and how to go about functional approach? Basics, just touching the basics. And what are the major approaches we already know? That is Roods approach, Bobath approach, Brunstrom approach, and the PNF approach. Along with that, we are also going to see motor relearning program, which is a activity-based functional training. So these are the three things you will be familiarized. And first of all, I will tell you that after listening to this, I think you have to do a lot of homework. Just this presentation alone is not sufficient for you to understand many things. And I will tell you how to sequentially go about your reading. So first of all, you might have heard this word a lot. This is functional activity-based approach, functional approach, task-oriented approach. This is what you might have come across here. This is not today or day before yesterday started. This is started in 1984, but it took a lot of time for this approach to reach globally, particularly to reach India. Even my teachers, and I was studying my undergraduation and post-graduation, did not stress much on functional activity and activity-based approach. So you can imagine how long it has taken for us to adopt this. So what is this? First, if you want to understand any treatment in stroke rehabilitation of patients, first you have to know what is motor control. What is motor control theories? Very important. I will throughout this presentation give example from cricket because I love cricket. So I'll give example from cricket. My teachers also gave me examples of cricket, so it's very easy for me to give the examples. The first thing is, if I wanted to bat, if I want to practice batting, it is not that I should have my pads, my bat, a high quality abdomen guard, the helmet and everything. Everything is there with me, fine. The ground is also ready. There are people to watch how I am playing, but the very important thing is I should know that how the game works, right? Even if I have all the gadgets, I should know how the system works. Then only I can go directly start playing. So it is not how
Sorry
many
for
techniques the
interrupting you.
therapist knows.
Your presentation is not visible. Did
Not
you?
visible.
Yes, sir. Your presentation is not visible.
My screen is not visible, or my picture is not
So
visible.
only presentation, sir. You are visible, sir. Your presentation is not visible, sir. You didn't
Oh,
share. You have to share it.
I think. Okay, again I'll share. Sharing PowerPoint keynote. Now is it okay? Now is that okay?
It's still blank, sir.
It is not visible.
No, sir. It's a blank page. You
Okay,
have to
one.
share it, sir.
Now is it visible?
No, sir.
Now is it visible?
No, sir.
I don't know what is wrong.
You have to share your presentation, sir. Yesterday,
So I'm sharing. Sharing a PowerPoint or a keynote application can cause issues in presentation mode. That's what is popping up in my. Sharing your entire screen will help here. Okay, fine. I think now
we got it, sir. Now
you
we
got
got it,
it.
sir. Yes, sir.
Yeah.
Yes, sir. Maybe make it bigger. Make it as a PowerPoint, sir. Okay. Slideshow.
Is it fine?
Of course, sir. Of course. Please carry on. Thank you.
Okay. So once you should know the motor control theory, you should know how the movement is happening in your body. Then only you can go and learn a lot of approaches to tackle this. So what is movement actually? Movement is interaction of an individual between the task and the environment. It is the interaction between these three things. If I am an individual, how I move in this given environment in the when I have a task. That is what is all about movement. Movement, just like that, do not happen in human system. With a task and in a given atmosphere only it happens. So it is very important for everybody to learn this motor control theories and how the motor control happens in your body. Next is very important. You have to know about motor learning theories, how learning happens. You know, every time you keep practicing a single activity, you become master of that activity. So even after so many days, you won't forget that particular activity. That is what is very important. That gives the importance for practice and repetition of a task in the management of stroke patients. And third important thing is the available evidences, which is very important. What is the research says, what is the body of science says about movement control and stroke rehabilitation. And very importantly, the abilities of the patient. You should know what is your patient's ability. You should not squeeze them beyond their abilities. If a patient is in acute stage of a stroke, when he is not able to move his upper limb and lower limb, you should not force him to go for a task-oriented approach, and you should not start giving him tasks. So the ability of the patient is very important. You should know what is your patient's capability. Fine. Just remember this. I'm giving a brief idea how to analyze treatment based upon these principles. Okay. So remember motor control, theories of motor learning, the available research evidences, and the ability of the patient combined together to form an approach called functional activity based approach. These examples I'll give you later. Now, in this presentation, I'll always be using this name activity and function, okay, or participation. So for that, you should know what is this. So we all know that 2004-5, this classification of impairment, disability, and handicap gave away to a new classification called ICF, International Classification of Function, which says that any health disorder or diseases can be divided into three presentation. One is body functional and structure. First thing, that is called as impairment. Which body function is not functioning, body part is not functioning well, that is called as the first one, which is the body function and structure. Because of this particular inability, what you are not able to do, for example, I'm not able to sit to stand, I'm not able to lift my hand above my head. So all these things are activity. So activity is limited because of the impairment. What happens because of this activity limitation? I'm not able to participate in my social activity, my occupational activity, my familial activity. So the participation of a person being an effective member in the family, society, is the very utmost important aspect of any disease. Okay, you go and ask any patient, the patient will say, I'm not able to go to office, sir. I'm not able to ride a bike on the road. I'm not able to go to office and earn money. This will be their major issues because of all the pain and sufferings they have, right? So how often we attest this thing is very important. We never take a patient to the road to walk. We never take a patient to the ramp to climb. If you are doing well and good, I'm happy, but most of them I have seen, they don't do that. So remember this classification which I'm going to use, this terminologies which I'm going to use. So which is going to influence these two things, the personal factor and the environmental factors. We'll see that later. So when I say functional activity, that is going to pertain to the participation, the social activity. The patient is walking inside the room, well and good, but is he able to walk towards the temple? Whether he is able to walk towards the railway station, that is called as the functional activity. Okay, in this presentation, if I use this word activity, that means sit to stand, walking, lifting the hand above the head, taking a box of water, a bottle of water from the table. If I say function, it is like day-to-day activity. Fine, day-to-day function, like going to office. It goes to the society or to the familial activities. Next is all the interventions which are given for stroke can be divided into two. Before this classification, I would like to say you have to involve the patient actively into this your treatment. If you're going to give any passive treatment like passive exercises, any IFT or stimulation, that does not have any evidence at all, you're going to fail, because ultimate aim of a physiotherapist in stroke rehabilitation is to make the patient voluntarily move. So if in case you're going to give some passive techniques, I'm very sorry, you're on the wrong side. So coming to the active exercise, these active exercises can also be divided into two. One is exercises which are actively attesting to the impairment level, and the exercises which are attesting to the functional and activity level. We saw in the ICF classification, first is the impairment, next is the activity, and last is the participation, that is function. So if you are going to attest only the impairment, my muscle is problem, there is a problem in the joint. If you go and particularly assess and give treatment to that particular muscle and the joint, or a group of muscle in that case, I think you are on the wrong side. That is not going to help any stroke patients. Simply by means of bending the elbow and straightening the elbow, if you're going to train, what importance it is going to create, or what improvement it is going to create in a patient's life, how it is going to change his day-to-day life quality, that is very important. So that's why I am saying all these things has to be in an approach. Then only you can say this approach is good. Now we will step into one by one approach. The first approach is called the Roods approach, which was designed by a female called Roods. If I am not wrong, almost all the interventions are devised by female in the field of physiotherapy, stroke rehabilitation. Either it be a Rood, Betta Bobath and Karl Bobath, Shumway Cook, and then Carr and Shepherd. All of them are female. So maybe it's a coincidence or not. That's why there are a lot of inacceptance and a lot of dispute among all these approaches on the lighter side. So coming to the Roods approach, what Rood identified in stroke patient, the major problem was tone. she said tone is a major problem, and I can normalize this tone by giving some sensory inputs. Even now also we say, I see a lot of students are calling me and asking, sir, what to do for spasticity. My dear friends, you can't do anything as a physiotherapist for spasticity. You cannot reduce the spasticity. If you think by stretching a muscle you can reduce the spasticity, that is not true, because spasticity is something which is a discharge which is coming from the brain. The hyperexcitability of the brain is causing the spasticity, or the spasticity may be an hyperactivity of a muscle, abnormal activity of a muscle. I think you cannot control spasticity as a physiotherapist. So one thing you can do is you can ignore this spasticity. Spasticity is not going to cause any trouble to you. But according to Roods, she said normalization of tone is her major issue. So critically, you are saying this, the first sentence itself, she's wrong, she's proved wrong. Next is she's saying you have to follow developmental sequences. What developmental sequences you want to follow? She says that if only a patient sits from supine lying to long sitting, then she can go for, then the patient can go for a high sitting. Then only the patient has to be taught for sit to stand, and then after once he stands without support, then you have to make him walk. This is developmental sequence. Yeah, definitely. And you also have this crawling and creeping in between, which if for example, if you are taking a stroke patient who is 45 years old, you ask him to crawl and creep, do you think he would have done this activity maybe for the past 45 years? He might have left this when he was 1 year old. Am I right? Even 1 year could have 6 months. He might have not used this way of locomotion. Maybe 9 months later, he would have started walking. When he started assuming upright standing, he might have not used this crawling and creeping. And why do you ask him to do a crawling and creeping when he's having stroke? This is the second point. Next point is, she also said there should be a purposeful movement. Purposeful movement is like touching a target, giving a target and touching it, and with some purpose. Like she also educated some facilitatory techniques, inhibitory techniques. These two are the very important techniques of Roods approach. When a person is not able to do a purposeful movement is reach for an object. Okay, if he is not able to do, use all your sensory modalities like your tapping, brushing, excitatory things to facilitate the movement. If the tone is going to interfere that, you reduce the tone by means of inhibitory movement, inhibitory activities. Still people are practicing that, but how far this is going to help? EMG study says that they don't have any activity, any influence on the muscle tone. So why to unnecessarily do this? So all the 3 points are shattered. Next, the repetition of movement brings about learning. Yes, this is accepted. More you repeat, more you become, more learning happens. So out of her 4 principles, 3 have been disqualified and learning is still there. So learning an abnormal movement, again, that is good or not? Yeah, I won't agree. All the 3 points, if they are true, then learning those true points is going to result in a better improvement. But if all the 3 statements are bad and you're going to practice something bad, and that is not going to result in any purposeful learning. Okay, so from my side, I decline this Roods approach as an ineffective treatment. I would also like to give you a disclaimer. When I say all these approaches are not effective, I have to tell it very humbly, because in those period, what are all the theories which were available? Based upon those theories, these the approaches have been formed. Neurodevelopmental theories, motor control theories, learning theories. What was there in that particular time, maybe 1950s, 1960s, they have come up with this particular approach. Now the technology is advanced. I'm on the top of the world with scientific knowledge. Now, if I say that Roods was stupid, Roods was not knowledgeable, I just like that use some harsh words for them, then I'm not a human, because these are the approaches which have been winning us bread and butter all these years, and now they are outdated. So we have to say that is very humbly that they are outdated. But their contribution to the neurodevelopment and motor development, motor control theories, and the management of stroke patients is immense. We cannot deny that. Coming to the next is the Bobath approach. So Bobath also was very concerned about the abnormal tone because they are contemporaries. Both Roods and Bobath were contemporaries. So their theory was based upon the reflex theory and the reflex hierarchical theory of motor control, which says that if I have some sensory input, then I'll come up with a motor output for that. So every movement in human body was taking place because of some sensory input, but they were not able to explain some movements which did not take place, which took place without any sensory inputs. Fine. So you have to go through the motor control theories to understand this. So Bobath also said the abnormal tone was a major problem. Next, she said loss of postural control. See, she's saying postural control. And motor, the abnormal tone we have already declined as a false point. Next is the posture. Now tell me which is a good posture, which is a normal posture. We normally say that sitting erect is a normal posture. So how long you will be able to sit? If this is a normal posture, why you are not able to maintain this normal posture for a long time? Why you slouch? If this is the most comfortable posture for you, then is that the normal posture? My teachers and my discussion with my colleagues always says that the definition for a normal posture or a good posture is always conflicting. Anything and everything which is comfortable for you, which is less energy cost, and you adopt it without any hesitation is a good posture. And I should not say good posture, optimal posture. There are some optimal postures for certain activities. If I want to take class in this PowerPoint, in this sort of a setup like in a laptop and talking like a mad person without seeing the audience like this, I have to slouch slightly and sit. If I sit like this erect and I teach like how I teach in my classrooms, I'm not going to solve the purpose, right? Am I right? Whereas if I'm standing in the class and taking a class in front of hundreds of students, I have to be straight. I have my eyes have to look around. So my body posture differs. So posture always depends upon the task and the environment, the context. That is what is very important. So when she said loss of postural control, a stroke patient, if he is able to sit like this, for example, this is his affected side, he is sitting like this for hours together and he is doing his activities, he is brushing, he is eating, whatever it is he is doing. A physiotherapist suddenly goes and says, you're sitting in an abnormal posture, you sit like this, you sit erect, your shoulders should be straight, the tragus should be in the line, and everything he does, this patient is not able to sit for 10 minutes also, and he's not able to do his functional activity. Every time he sits like this, his patient's attender says, physiotherapist, I've told you not to sit like that, you have to sit erect, you have to keep your hands like this, and you have to do, and he becomes very inefficient. You agree with me or not? So when you say postural control, posture depends upon the environment, the task, and the individual, as I told you already. So this is proved wrong now. Next is abnormal coordination. So what is abnormal coordination? Abnormal movements that is taking place in stroke patients. They say that if there is a spasticity, the patient will not have coordination. So you have to start giving him teaching him normal coordination. As long as this point is concerned, abnormal movement or normal movement, if the task is accomplished, I am happy. If you expect for the normal coordination to happen and if you procrastinate giving the task training, that is not going to result in any amount of improvement, because mind you, your neuroplasticity is going to be at its helm at the first 6 months. Once the 6 months is gone by, the neuroplasticity is slowly going to go down. Recently, I saw someone who posted in the Facebook, like a person trying to push the train. Fine, the train, even if you push or not, it is going to run. But our role in most of the conditions is like facilitating the normal recovery pattern. So how you are going to facilitate this normal pattern? As early as possible. So if you keep wasting your time in normalizing the coordination, normalizing the tone, normalizing the posture and everything, when are you going to train the function? When are you going to train the activity? So that is very important. So we declined the first 3 points. And the fourth point is abnormal functional performance. So again, this is Bobath. Initially, he came up with an idea like you have to keep anti reflex inhibiting patterns where you have to keep your neck slightly flexed for increasing the tone in the upper limb. And she came up with all reflex inhibiting patterns, making the patient to lie prone or supine, influencing the labyrinthinic reflex. All these things she came up, and later she found out that this reflex is not going to influence anything. And she came up with an idea that you have to start training for function. So this word, they say abnormal functional performance, she coined it because of the circumstances. The theory started changing later on. And she was not able to sustain with her previous theory, so she came up with something called improvised neurodevelopmental theory, in which she said function is very important, but this function is not a real function what she mentioned. So for example, she asked to start giving functional training from supine lying. So what is the major function in supine lying? We don't know. The starting position itself should be a functional position for you to teach some daily activities. If you are going to start from side to supine lying to side lying and then lifting your pelvis, all these things, if you're coming and telling me that is a functional rehabilitation, then I think it's kidding. So the four thing principles or the problems she faced in stroke patient is also declined. So I'll run through this slide. Yeah, another thing she told was there are some key points in the body. The central key points is the trunk. The peripheral key points are the shoulder and the pelvis. And then she said the distal key points are your hands and the feet. And there are no key points in your body as such. Have you ever noted such things happening? This happens with kids, handling the kids. It may be true in case of the kid where you touch certain areas. The kid is highly dominated by the reflexes. But it is not true in case of a stroke patient, and all these things have been proved ineffective in case of the research knowledge we saw in the initial slide, how you have to correlate these learning theories and motor theories with the knowledge of research. When you see the knowledge of research, they are proved wrong. So all the things Bobath came up with have been proved wrong. And next we are trying to prove Brunstrom wrong. So Brunstrom, what is the significance of Brunstrom is I like him very much, like her movement control, her theory a lot, because she was little different from all these people. Her classification of motor recovery still is being used by many researchers worldwide, and though most of the things have been outdated in her thing, still now for acute phase management people are using her concepts to effective ways. But if you see research wise, it is not proved right, and you can adopt certain things from Brunnstrom in your clinical practice, which you will do as you evolve as a practitioner. Franklin, I think I'm audible.
Sir, you're audible, sir. You're audible,
Oh,
sir. You're audible.
yeah. So now this stages of motor recovery was defined by Brunstrom. She did not define this just like that. She defined it after seeing so many patients, how did they behave and how they progressed over a period of time. With that, she said that these are the 6 classifications of stroke development, improvement, how they progress. What was her principles? Again, she emphasized on developmental sequence. We have already proved that wrong. So she said one thing very differently, that the movement proceeds from isometric to eccentric, then to concentric. So in her treatment also, she's emphasized one should start giving isometric exercises initially, then that should go to the eccentric exercise, then Last, you have to teach people for concentric. Every muscle has these three functions, right? So she said in every muscle, you have to increase the muscle tension by means of giving isometric, then eccentric, then concentric. This is proved wrong because eccentric is the most difficult activity for a muscle to do, which is being proved now. And isometric activities are also difficult. The most easiest is the concentric activity. So she asked the physiotherapist to train the most difficult activity initially and then go to the easier activity, which itself is proved wrong nowadays. Next is facilitation. When there is no movement exists, you have to facilitate. She had some quick stretch, and then she had some facilitatory techniques, touch in certain zones of the body to facilitate the movement. But they are all proved wrong now, because there are no zones in your body which you say, like I have seen my teachers, my undergraduation say, you don't touch the palmar aspect, you touch the dorsal aspect, so that patient will do much of excitatory wrist extension. Proved wrong. There is no scientific evidence for that. Handling is not that important because it's all passive technique, which is not going to be useful for patient to do his activity. What you have to concentrate is on active techniques. Yeah, you can assist patients, but you can assist patients from any place where that will not affect the patient's ability to perform the activity, or it will tamper or reduce his potentials. Got it? So this is wrong. And she said facilitation should be slowly stopped. The voluntary control will develop. And that is also wrong, because as long as you give a facilitatory technique, I have not seen in my clinical experience, I was not able to withdraw this facilitatory techniques once I involved. Like when you repeatedly tap a muscle, you feel like the muscle is slightly moving better than before, but that is not true. Uh, it's because of the mentality of the patient or the excitability of that particular muscle. You are stretching the muscle. Any muscle which is stretched tends to rebound. Am I right or not? When you sit to stand, your plantar flexors are being you have to tuck the legs in for you to do an effective sit to stand, because your plantar flexors are in a stretched posture. From that stretched posture, once you release, it gives you a good muscle activity. That is what you're seeing, nothing more than that. So at any point of time, you won't be able to reduce the facilitation technique and bring about voluntary control. It is, you are cheating yourself. The neuroplasticity is happening, the patient starts doing it better, and you feel like all your tapping, brushing, and applying of your toothpaste and everything has given results for the patient. If you think like that, it is wrong. Okay, so always involve in activities which are functional, goal oriented, and which is always active. Fine. So now next is the proprioceptive neuromuscular facilitation. I'll tell all my students who don't know what is PNF are the most gifted people in this world, because it is not important for you to understand anything about PNF, because PNF is the most difficult theory to read, first of all, and it is even more difficult for you to practice on yourself. And the third important thing is, it is impossible for you to practice it on the patients. If somebody says that I am practicing PNF very successfully, I used to wonder, I used to see him like a Shiva or a Vishnu or whatever God you know. Because imagine the patient, we'll go to the concept first and then I'll tell you. So this PNF is very well known for the patterns, you know about it. D1 flexion, D2 flexion, D1 extension, D2 extension. All these things are good. I will really agree with certain points what PNF said. She said every person has an potential which is have to be discovered. Every patient has a potential. We should not underestimate any patient. We should not think that this patient will not stand up. Suddenly he will stand up, because his potential will be, anytime it can be tampered. All these days you may say that you will fall down, you don't do this, that. They will protect him like anything. They may have not used his potential to the maximum. But when the patient is made to stand with a lot of reassurance and support from the therapist, he will suddenly stand. So that is a very important concept. PNF said every individual has a potential, and it is up to the therapist to tap that potential. Yes, I'll agree with that. It's a philosophical point. Okay, and next she is coming. Every movement in our daily activities, functional activities, are diagonal in movements. Nobody do a single planar movement. Yes, I do agree. We don't do like that. Everybody agrees. We always do a combination of this. If I do this movement, it's a combination of frontal plane, sagittal plane, and the transverse plane. All the movements are there. There is rotation there. There is amount of flexion. There is amount of adduction. Everything is there when I take the foot to my mouth. Yes, it's a diagonal pattern. So when I eat, my hand goes like this and that. So it's a diagonal movement. We agree. Even if we are going to pull something from down, we pull it like this. Okay. So everything is diagonal pattern. I agree. Next thing is what she said is everything is reciprocal in activity. Imagine I'm going to a fridge, opening the fridge, taking a bottle of water, drinking the water, keeping it back, then closing the door. Whatever I have done, the reverse also I have done. So reciprocal movement. I take it like this, bring it down. Open the door, close the door. So yes, we agree this also. These are all from the observational point of view of a normal person. Yes, we agree all these things happens with normal people. But what about the abnormal person? What she says about the abnormal person is what is more disputed. Okay. That's what she said. It's an oscillation between extension and flexion. So when you do flexion, when you do axing, you do extension and then flexion. When you do eating, you do elbow flexion and then extension. So yes, this is normal person. So how to re-educate that? There she was having a lot of problems. So next is multisensory input facilitation motor learning. So she emphasized more on the proprioceptors. You have proprioceptors inside your joints which send information to the brain that your movement is taking place in this direction. Your hand is positioned here, your shoulder is here, your elbow is approaching the object. All these things are proprioceptive inputs. What she said, by giving more proprioceptive inputs, you can bring about better movement. When you give more and more input of sensory into that, then you can promote the motor learning, which is not true. If I make you sit on a cycle and I make you press all the areas, handbars, the pedals and everything, I hold you like that for 100 hours together, will you be able to drive the cycle? No, you won't be able to drive the cycle. Whatever sensory inputs I am giving you, I am putting the stand for the cycle and I'm slowly moving your legs in the circular direction. Do you think this will give a proper sensory input to the brain? No, it will not give. Unless otherwise a patient experiences it on his own, that is not going to give the sensory input to the brain as if the patient is moving. This information, what a therapist is assisting a patient to do, will send its own sort of information to the brain that somebody else is moving. Then how do you expect a patient to bring about motor learning? What is learning? More you start doing an activity, keep doing an activity, practice, this becomes learning. Learning results in skill. Fine. So this is proved wrong. More the sensory input, more will motor learning is what she proposed. That's proved wrong. And then goal-directed activities coupled with techniques of facilitation are used to hasten learning, that is to improve learning. Again, you can see all these theories are posting some absurd things initially, and finally they are stating functional activities must. Functional activities must. So it is like doing all the 3 steps wrong, and the final step you say everything is good, everything is for good. That is not a proper treatment, right? All the 4 steps should be meaningful, objective, and useful. It's not only the last step. You have seen all these things, Roods approach, Brunstrom, and this Bobath. Now, PNF also says the goal-directed activities, functional activities is very important. And I'm very sorry, that is not going to result in any objective goal-directed activity. Now, certain important things she taught was this D1 flexion. Imagine how we are moving in D1 flexion is functionally reciprocated is, see, it's useful. She observed normal people and said, these movements are day-to-day activities we are using. Because people will jump on us and say, D1 flexion, D2 flexion, nowadays also we are using in sports rehabilitation, we are using in low back pain management, all these things. How you can say this is wrong? See, my dear, these things are all evolved by mere observation on a normal person. You can come up with hundreds and hundreds of theories seeing a normal person, but what is stroke? How stroke people behave? How stroke people are going to come out of this problem? Do you think they are all normal? Do you think they can do an elbow extension in shoulder flexion with wrist extension and all these activities? Do you think they're going to take a racket and play a tennis sort of a thing within a matter of a minute? No, unless otherwise you practice, you make them do their activities which they have been using all these days, then only they are going to recover. You suddenly come and introduce some sort of patterns in their life, you ask him to do that movement, how they will do? No, they cannot do. But these observations, what she made was very important for the progression of the next level. She was very confirmly saying that movements do not take place in a single plane. Please don't teach elbow flexion. Now also I see a lot of physiotherapists teaching kai mela thookunga, kai side la thookunga, thooki enna apodhu. Nothing is going to happen. So very importantly, you have to train the task and function. Fine. She also said that our functional activities are either symmetrical or asymmetrical or reciprocal. Just see this upper limb activity. It lost a lot of meaning in that. Look at the lower limb activity. Have you ever been into these positions in your functional activities? No, it is very rare. Yeah, it can be true for upper limb and it cannot be true for lower limb, and it looks very different. Now coming to the motor relearning program. Motor relearning program is by far a breakthrough in the management of physiotherapy for the stroke patients, and it took a lot of time for these people with motor relearning program to convince people saying that this is the proper way to treat people, because Bobath has started treating people with Swiss balls, therabands and all these things. So when she came and said that, see, you don't need all these fancy gadgets and you need only the atmosphere and ambience what patient live in for retraining the patient, then everybody said, then what is the role of the therapist? You want me to hold the patient just for a walking training? You want me to go behind and come back? These are all the problems motor relearning program faced initially, but now it is the most accepted form of stroke management worldwide. So they had 7 important consideration areas. They did not go with upper limb training, lower limb training, trunk training and all. They said you have to facilitate the upper limb function, orofacial function, supine to sitting function, sitting to standing, and very importantly, standing to sitting. I often see many therapists give more importance for sit to stand training, but they don't give much importance for stand to sit training, because stand to sit training is very important, most ignored part of physiotherapy management of stroke patients, which can lead to a lot of falls. The domestic falls, most of them happens during walking or standing to sitting. Most of the time, because the chairs are plastic chairs and very lightweight chairs, patients do not know how to sit. They just like that drop their body weight onto the chair, and either the chair moves away or the chair breaks, or they are sitting in an inappropriate position and they fall. So very important thing, stand to sit. And then standing and walking. So these are the 7 considerations she gave for management of stroke patients. So she had 4 steps for every patient to manage. I'm going little elaborate into this because I think I'm not late. We are we're already 45 minutes into it. So I think we can have this as other session also. I'll finish up with motor relearning program. So first phase is you have to analyze the function, how the patient is doing an activity. For example, if you imagine a patient is sit to stand. Sit to stand involves bending your knee, bending your hip, and then propelling your trunk forwards, and then standing up from this by means of hip and knee extension and plantar flexor pushing you up. Fine. This is called as sit to stand activity. When you are analyzing this activity, you are observing first. The first phase is observing and comparing with what? Comparing with a normal person's performance. So you should have a good idea about how a normal person will do that. Okay, this is first stage. Once you observe a patient and compare it with a normal person, and you will analyze what is the problem with this guy. The next step is you will find that this person is not having, he's able to bend his knee, he is able to bend his hip, and he's not able to propel up. His hip extensors and knee extensors are weak, so he's not able to propel up to standing. So what you do is you go back to the impairment level again. Now we are attesting to the activity. Activity is sit to stand. So in this activity he is not able to do because he is having an impairment in his quadriceps and his hip flexors. So you go and train the iliacus and psoas major, and then you also train the quadriceps muscle. Once you keep training these two muscles, they become stronger, and then you have to make the patient do it repeatedly and practice it by means of verbal cues and everything, and he will gain control of this particular movement. And then next is again you come back and practice the activity. Now the patient will be able to stand much better than before because his quadriceps and iliacus and psoas major are being trained better, and now he'll be able to stand. Got it? So practice is a very important thing in all these stages. So progression from this place, from the practice of the activity, how you have to progress is you have to increase the complexity of sit to stand. You can change the sitting posture, like you can change the height of the chair, or you can give a arm rest chair initially, and then you can reduce the arm rest, and you can ask him to stand from a stool. Very importantly, you have to train the toileting activities. You have to make him sit on a Western commode. And if a patient is very much comfortable with Indian type of toilets, definitely you have to train sit to stand from that particular posture. And all these things are there. That is what I meant by means of context. Activity is performed in a context, and that context is very important. So this is how you have to increase the complexity. Most of the therapists are very happy once the patient performs sit to stand from a level chair, but that is not sufficient. The patient goes to a park, he sits on a low stool or a low table or something, and he's not able to stand up from that place. So you may be good in treating the activity, but that activity has not transferred into a function. So that is where you are lacking. And very important thing is decrease your feedback and guidance. Don't give much of assistance. Don't give any verbal feedback or manual guidance. Reduce it. Let him do on his own. That itself is a progression in the difficulty. And once everything is trained in the activity level, transfer of learning, opportunity to practice on his own, practice in a different environment, okay, and then consistently do that. Practice should be consistent. That is very important. Okay, so you teach all these things to the caregiver also. Ask him to monitor all these things. Ask him to do in his presence, and also involve him into the team. And simulating the actual atmosphere is very important. For example, if a patient is a roadside vendor, he is selling flowers in the road. So she should be helped to sit on a very low chairs, because normally you see these people who sell flowers, they sit on a very low chair without any support. They have to move either ways to reach out to objects which are kept on the floor, and you have to train all these things, right? So sitting alone without doing this movement is not going to help her functionally. She can't go back to her work as of now, because she has to sit like this without any activity down this way and that way. So as a therapist, you have to practice what are all the things that is needed for a person to go back to the functional life activity. Very importantly, you have to simulate that. So in your clinic also, you can make a small stool, ask her to sit on a stool with a desk in front with a lot of flowers in that, and let her have her money below, and on the other side let her have her water or foodstuff or whatever it is. Mimic as if she is selling something, and mimic as if she has gone back to her routine, and see how she performs. If there is any missing component in that, again come back to the phase 2, train that activity, incorporate that in the activity level, then come back to the function. So finally, the patient should be effective in performing her functional activities in the day-to-day activity. That should bring about some sort of a change in her life. That is very important. Fine. Franklin, if I can have another 5-10 minutes, I can finish it, or we have any time
Okay, sir.
constraint?
Maybe you can take in 5 minutes, sir. Maybe that'll
Oh.
be good.
So don't be confused what to use and what not to use. There are a lot of positives in studies which are outdated, but your aim should be making the patient functionally fruitful. That is very important. I'll just quickly run through what are the things you have to do. You have to do active exercise, which is goal oriented and functional oriented, and you have to repeat it many times. And the activity should be meaningful. Come on, you tell me, all these activities are meaningful? Is this stroke patient going to stand on a trampoline? Are you going to use your arm with the Swiss ball to do some activity? The last one, this fellow, see, gimmicks, he's doing a lot of gimmicks. He's sitting on a Swiss ball and he's having some softness in his feet. What you're trying to do, you may say that patient, you can tell to the patient that more sensory input is going there, you're doing a difficult job and all these things, but I'm very sorry, this is not going to help the patient in any way. Instead of that, if you ask him to stand without anything, you stand from a stool, sit without falling in a stool, that itself a great contribution you are going to do for the patient. Fine. It should be meaningful. Whatever activities you are doing, it should be meaningful. Attesting impairment, then you go to the activity. Many people don't agree that. So even I don't agree that. We will have this as a next class if time permits. Why to waste time now? And this is the message I wanted to tell you. The intensity of practice is very important. You might be knowing some muscle called as palmaris longus. You might have studied in your undergraduation. But now the research says most of the people are losing this palmaris longus. Many people are born without palmaris longus. Some of them have this palmaris longus on only one side, and few of them do not have it on the either side. Why? How do you see palmaris longus? When you touch your thumb with the little finger, the muscle which pops up here is the palmaris longus, right? I have my palmaris longus on both the sides. You can test with your sides. If you are young people, you may not have it. Why we are losing it? You may say that it is a small muscle, but it is not a small muscle, it's a large muscle. Whereas if you see Anconius is not at all useful in our day-to-day activity, but still we are having Anconius. If you see 100 people, all the 100 people have Anconius. How one muscle which is not at all useful in your life is being present in every human being, but certain muscles which are not, which are useful in a human being, they are not present. They are slowly going away from human being. We are still evolving. That is because palmaris longus was used by many animals and our predecessors for grasping onto certain object. Those days we had a lot of upper limb activity. We had to climb. To my knowledge, even I have climbed trees. I have climbed some walls in my childhood, but my son has hardly done that. Even if the ball falls into the next house, I have to do that even in this time. He never does that because human beings are slowly reducing their upper limb for climbing activity, and this hand grip of individuals is going down. That's scientific proof. So when you are not doing this particular activity, which is very important when you are grasping, so this muscle slowly fades away from human being. Whereas Anconius is used when a child is crawling and creeping in the early childhood, which is very active, which EMG study says, so this muscle has not gone out of human being. So if you use then it will be present. Use it or lose it. This is applicable for stroke rehabilitation also. The more earlier you start training the patient to do a functional activity, he will regain those functional activities. More time you waste in managing the tone, expecting the tone to develop, or reducing the tone, or correcting the posture, by the time his neuroplasticity would have gone out, the functional ability of the patient to the ability of the patient to learn the function might have gone away. So, as a physiotherapist, we have a very vital role in treating patient at the correct time with correct techniques. So, that is why we are having this presentation. And finally, also give a very due respect to people's behavioral issues. Behavioral issues are very immense. A patient may be completely demotivated and depressed, and a physiotherapist walks in and asks him to do exercises and do this, that, and the therapist will be highly motivated, but the patient may not be. There also, the patient will not progress very easily. So, involve a lot of clinical psychology, counseling into this. Take the help of your team members. Particularly, until I worked with an occupational therapist, I never knew the value of occupational therapy in the field of physiotherapy. We always used to fight with each other, but the contribution of occupational therapy is immense. They have a very good knowledge about cognitive behavior and cognitive management of a patient better than us. And I feel physiotherapist is an effective team member, and effective only when he is part of a team. So this is said by me. I can take a lot of credit in that. This I wrote when I started working for a team of rehabilitation. So whenever needed, you have to take help of the rehabilitation team members to improve a stroke patient. So with this message, I finish my presentation. We will definitely meet in another presentation where we will see how to functionally train the upper limb or lower limb, or again, how to go about functional training, which is my interest area. Thank you so much. Thank you for the opportunity. And if you want to contact me, you can contact me through Sairam Academy in YouTube channel, or you can come to my blog and you can message me, or you can mail me also, or you can reach out to Hamsa team to ask for your queries. Now the session is open for discussion.
Thank you so much, sir, for enlightening about the stroke rehabilitation. It was so good, and really thank you. We got a recap of our all modalities and approaches, and it's so good to hear. And Q&A session has been open. Please, participants can send your questions, sir. I already sent 2 questions, sir. To be able to view, sir, and I've sent it to your WhatsApp. Maybe you can have a look. I have a 2 questions.
Yeah.
Priya Chodi, regarding 2 questions. After 6 months, that's after the neuroplasticity stage is over, can we expect for improvement in ADL activity for stroke patient?
Yes, definitely you can expect improvement, because the neuroplasticity we say is getting over within 6 months or 1 year. It is not true. The intensity of ability, or the ability of the brain to change and modulate slowly decreases. That is what. But most of our research says that your acute care program of physiotherapy lasts for 6 months or 8 months maximum, um, and after that your plasticity goes down. There may be a relationship between physical therapy intervention in a patient and the neuroplasticity going down. At any age you can learn, right? Am I right or not? At any age you can learn. So more longer the physiotherapy management, you can sustain the neuroplasticity very effectively if you are able to change the context and difficulty of management. And don't think that after 6 months the plasticity be over and you can say that the patient may not progress from there on. I have seen patients after 3 years also progressing functionally. They may perform an activity little shabbily. For example, taking a cup of water, they may do like this. but if they're able to drink the water, I'm happy. I'm able to achieve the function, right? So that is what you have to aim. Don't think that after 6 months it will come down.
And there is a second question, sir.
Yeah.
So, what is your view on outcome measures used in both inpatient and outpatient setting with stroke patient, considering the floor and ceiling effect observed? Would you recommend any evidence for appropriate use of and particular measures?
Yeah. When it comes to outcome measure, you should know whether it is a valid outcome measure, reliable and sensitive outcome measure. This is basic category for any outcome measures. Fortunately, physiotherapists handle, out of the four types of outcome measures, we handle mostly nominal scale and an ordinal scale. Uh, we don't have any objective tool to say that the stroke patient is improving. Okay. We don't have much of biomarkers as such to use in stroke rehabilitation. When you say about 6 meters walk test, 6 minute walk test, or stand up, go at test, all these things, the flooring does matters. It's a very good important question. What you asked is the flooring really matters a lot. The performance of the patient, but if you do your pre-test and post-test with the same flooring, I don't think there won't be any difficulty in gauging the patient's progress. Most of the outcome measures we use are non-parametric in nature. Unfortunately, very few parametric outcome measures we have. If you want me to suggest some scales, I will say Barthel index is a good functional measure, and since functional independence measure scale is also a good outcome measure. But what you are intended to measure is very important as a functional outcome. Based upon that, I would like you to go for scales.
Sir, other the questions I have sent you to WhatsApp, sir. Can you check it, sir?
Yeah.
Questions are welcome. You can feel free to ask questions to
How
Dr.
about the use of
Arunachalam.
See, constraint induced movement therapy? Somebody has asked me. Constraint induced movement therapy initially was a hype when I was doing my post graduation. Everybody was willing to do a constraint induced movement therapy where they constrain their normal side and make the unaffected side to move. Remember, if a patient is having some failure in doing some activity, he will not be motivated to do any activity. For example, you are constraining a patient for 8 hours. Next day you go see him, he will develop an apprehension towards physiotherapy and apprehension towards the physiotherapist personally. These are all the practical difficulties in the field we see. Unless otherwise you give the affected limb the experience of normal movement or a chance to perform with the unaffected limb, uh, I think most of your functional activities involve affected limb, right? Sorry, both limbs. Am I right or not? Even if you are writing, you are going to use your hand for supporting and another hand will write. Even if you're opening a bottle, you use both hands. Try to simulate normal day-to-day activities rather than imagining something different like constraint induced movement therapy. How often a normal person will do with one-handed functional activities in a day-to-day life? It's very rare. So constraint induced movement therapy is a failure because of this particular thing. Next question. Neuroplasticity does occur in normal individuals too. Yes, definitely. Neuroplasticity is the ability, innate ability of a human brain to remodify, model itself based upon the action it is doing. Imagine this is the lockdown time. I started playing guitar. How it is possible for me to learn guitar? My brain neuronal circuits starts changing and help me in learning that new activity of guitar. I have learned a lot about YouTubing. I have learned a lot about the technology thing. How it is possible? Because my neuroplasticity is taking place. Neuroplasticity is not only what to say after stroke. It happens. It happens in everyday life. More you learn, more you modify the neuronal circuits, That is also neuroplasticity.
Other questions I have sent it, sir. And we'll wind up
How,
with the last question, the views on mirror therapy, sir.
how will be the management of stroke patients initially admitted to ICU? Our role is very less here. When you are going and seeing a patient who is comatose or who is cognitively not stable, and you have all passive treatment giving on him, you are going to hurt him a lot, particularly on the shoulder. If you're going to move a person's shoulder from 90 degree to 180 degree by saying that I'm giving passive range of motion in an ICU setup, in fact, you are hurting his shoulder because he is not able to give you the feedback. That doesn't mean that you're not hurting, you're hurting his shoulder, because this 180 degree of shoulder flexion abduction takes place in 4 joints. It's a glenohumeral rhythm. But here you are going to move only the glenohumeral joint for 180 degree. That means you are hurting his his shoulder a lot, and when he's coming back to sensory normalcy, he's definitely going to have some shoulder pain, and his shoulder is going to sublux, or in the unfortunate scenario, he's going to dislocate. So please don't do any passive interventions when the patient is in acute stage. Yes, it's very tough. It's better we don't do anything. People say that I want to maintain the range of motion. Yes, you maintain the range of motion in functional range. Normally, beyond 90 degree, we don't have much of functional range for the shoulder. You give passive range of motion. If at all your management asks you to give it within 90 degree. Elbow also, slight elbow flexion and extension. Don't take it to the extremes and force the joints to certain level where you are. And very importantly, don't give this pulley exercises. Normally, what physiotherapists advise patients to go home, use a overhead pulley, hold your normal hand with your normal hand, pull your abnormal hand up and down, right? That is going to hurt the patient. So please don't do any passive modalities when the patient is not well. Imagine his time will come, you can treat him later on. And
there is a next question also too, sir.
how can we functionally train a stroke patient who is acute and bedridden? Yes, this is a big in acute phase. You mean acute phase is a phase where you have cerebral shock. How I can define cerebral shock is, you're driving a vehicle, you're going very fast, suddenly some lorry comes in front of you, your leg starts flattering and you don't know what to do, you all systems shut down, and you face I should not say you, somebody X faced with an accident. This is called cerebral shock. This is a situation of the brain where it is in a critical situation, it is not able to discharge any output from it, so it shuts down. So in case of a cerebral shock, you will find stroke patients having no tone, no reflex. So in that scenario, it's better you don't do anything. You maintain the range of motion within the functional levels by doing minimal 30 to 40 degree range of motion in all the joints. Just give the feel for the joints of movement. That's it. Don't take it to the extremes. Our role in acute area, when the patient is not the cerebral shock is not resolved, is very limited.
And next question is all about the mirror therapy, sir, and they're asking about your views and what about mirror therapy.
Yeah. This mirror therapy was formulated by the idea was given by a book called Qualiers of Brain. Qualiers of Brain was written by Univeristy Ramachandran. I'm so fortunate to be from his district. What he said is, what your brain sees, it behaves. That is what he said. There are a lot of research evidences for mirror box therapy, where you insert your hand into a box where your affected hand is not at all seen, and your normal hand moves and your brain sees that you are moving both hands. Again, now this is a passive treatment. You are not moving your affected limb. As long as you don't give the experience for your affected limb the moving option, um, basically it is not correct. but we may never understand how this happens. The brain is entirely different different entity. Fascinating thing, how it behaves, nobody knows. But I have got a lot of positive feedbacks from mirror box therapy. I will tell you one thing: if it is clinically effective for you, and if it is not harming the patient, please go ahead with that. There is nothing wrong in that. If you are not going to procrastinate the patient's recovery by means of experimenting onto that, or for the sake of treating, if you are treating with crude abnormal signs, then that is wrong. But if you feel this is going to improve the patient, there is nothing harm taking 10-15 minutes extra from your normal treatment routine. Giving this mirror box therapy will definitely help. That's what I feel. One more question. How effective is virtual reality and biofeedback techniques? Yeah, biofeedback will be effective, but for what you are taking a feedback. For example, if you are going to ask the patient to do elbow flexion and extension, for this you are giving a feedback to the patient. I'm sorry, that is not going to help. Am I audible?
You're audible, sir. You're audible.
Yeah. So if you're going to train an activity, you're going to train a function. For that function, you're giving feedback through EMG biofeedback, then that's well and good. For a simple example, if you're going to take the feedback from the quadriceps when the patient is doing sit to stand, and you tell the patient that you have to match the ghost image when you're doing this sit to stand, your activity level of your quadriceps is less. You can actually recruit that by means of pushing your knee a lot. And if the patient takes the success by means of seeing the visual feedback, definitely that is going to help. But feedback, I will be telling you which activity you are giving is very important. And virtual reality is a science which we are coming up with a lot of experiments. It is still in experimenting level, giving a new ambience. You give a goggle to the patient, he behaves in a different way. Uh, I have experienced it. I have played a game with virtual reality. You go into an entirely different world, and automatically you start moving, and you don't know, your efficiency is increasing slowly. You keep up your pace with the game. I think this can do a wonder for stroke patients, where for simulating the atmosphere, you can use this. For example, if the patient is working in a librarian, if he isn't librarian, his job is to keep all the books on the rack, on the down rack, center rack. So how you will practice the same thing in your clinic? If it virtually, you ask the patient to wear this virtual reality goggle, and he will see the entire library in his world, and he will start doing that movement. So simple. So virtual reality is going to help. It's a boon for our field.
And one more last question, sir. What is the difference between functional re-education and motor relearning program? We'll wind up with this question, sir.
Motor relearning program was the one which gave way for functional training. So as I told you in the classification of international classification of function, you have something called as impairment, activity, and participation. So this participation, when the patient goes to the society, we call it as functional activity. Motor relearning program was the one who started training patients functionally. Until then, people did not give a shit about this functional training. Motor relearning program started training function, and it is interchangeably used nowadays. But many people have brought about a lot of changes in that, like people like Shumway Cook have brought about a lot of, not lot of changes, simple changes in that. I'll tell you one small example in that. Static balance வந்தாதான் டைனமிக் பேலன்ஸ் வரும் அப்படிங்கிற அந்த தியரி இல்லை இப்போ. டைனமிக் பேலன்ஸ் கேன் டெவலப் ஈவன் வித்வுட் த ஸ்டாட்டிக் பேலன்ஸ். So when you training function, when you train static functions first and then you go to dynamic functions, that is what motor relearning program taught. But now it is not true. You can directly go to dynamic functions. You need not wait for the static functions to come up. And another thing was like the proximal have stability function and distal have mobility function was what educated by motor relearning program. But now that is not true. When you are holding on bus, or when you are standing on a moving object, your upper limb and your hand becomes a stabilizing factor rather than your lower limb and your shoulders. So context and the environment differs a lot, based upon which you have to train your patient. That is what functional training is all about. Functional training is what the interaction between the individual, environment, and the task.
Okay, sir. Thank you for your wonderful presentation. Thank you for lending your time on this period. It was quite informative, and
Thank you so much.
thank for the people who have participated in this webinar. And we are coming with many more webinars, and we are planning for a workshop where we are planning with Sir. We'll be conducting a workshop, and we are planning many more things. And as we discussed, there will be more. He was planning about a virtual reality workshop too. Maybe in the future we'll be coming on with many more. And thanks a lot. Thank you so much, sir, for giving this opportunity, and been very kind towards us. And your webinar was really good, and it's quite enlightening for us. And thanks a lot, sir. Thanks a
Thank
lot.
you, Dr. Franklin. Thank you, Hamsa team, and we will work in the future a lot, associate in the law in a better manner. Thank you so
Okay.
much.
Thank you so much. And here we are. I'm winding up this session. So this is we are on a we are having a setup called Hamsa Rehabilitation Medicine, and it's mostly works on stroke, brain and spinal cord injury, brain rehabilitation and spinal cord injury related condition. We are placed in Gopalapuram. Maybe you can see you can go to our website. It's an AMSA, and even I'm going to play you a little bit of regarding our advertisement. Maybe.
They are totally dependent on someone, even to brush their teeth or to use a toilet. Look.
So once on, thank you for all participants. We are winding off. So you can visit us through our website, and you can even send us mail regarding this webinar. We'll be sending you a feedback. Kindly fill your feedback, and we are happy to hear you. And thanks a lot. Thank you so much.